I'm Steve Schuster from Philadelphia, and I'm here at EHA 2026 in Stockholm. And I had the opportunity to present data for the ANTLER 1 study yesterday at the meeting. These are data that I'm quite excited about. I've been, as some of you may know, dealing or helping to develop CAR T-cell approaches to therapy for the last 15 years. And this is an allogeneic CAR T-cell approach that is unique from other allogeneic CAR T-cell approaches in that these cells are engineered to not express PD-1, so this improves their lymphocyte fitness and persistence over the period of time post-infusion. It's necessary to achieve a remission, as well as the CAR being inserted into the T-cell receptor gene locus so that these cells don't cause any graft versus host disease, but they're not going to react to alloantigens. They're specifically going to react against the tumor target, CD19 in this case. And the data look really spectacular when they did the initial dose finding study, looking at all the data in aggregate. What emerged was that patients under the age of 30 that were donors created products with which patients had much better outcomes. So lymphocytes from young people are better than lymphocytes from old people. The other thing that emerged was if there's a little bit of an HLA compatibility, just two antigens, which honestly, it's very easy to find a two antigen match, you had better outcome. So it looks like, using the lymphocytes from young donors engineered the way I described earlier, using those lymphocytes, you see persistence over about a month, and then they're cleared. It seems as that's the amount of time you need to take to get a response. Looking at the group that got young donor cells at the recommended phase 2 dose after the dose escalation portion, we call that the pivotal optimized group, because we're going to match those patient and product characteristics to the randomized pivotal trial that's planned. There's, I think it was 67%, 2/3 of patients have complete responses, and the majority of those responses are durable. Only 2 patients who had complete responses at 3 months had progression. The rest have stayed in remission. And that really bodes for the fact that it's likely to be durable response. So I think this is going to be important for patients with large cell lymphoma. A new therapy, it may make the CAR T-cell approach easier to apply in the community, since you don't have to have apheresis facilities and even be near an academic center. Some of the centers on this trial were community center. It's because the product's very well tolerated. There was no severe ICANS, and I think only one case of grade 3 cytokine release syndrome in the pivotal optimized patient group. So I'm optimistic. I think this is going to be a game changer. We'll see. The pivotal trial is planned. Hopefully in the last quarter of this year, it'll start. And hopefully this will be a product in a couple of years that makes the CAR T approach available to many more patients. As it stands right now in the US, CAR T is approved for second-line therapy of large B-cell lymphoma, and only like 25% of patients are actually getting it that are potentially eligible. And a lot of it has to do with access issues that are related to geographic things, so socioeconomic factors, financial factors, or just the tempo of the disease. You have to manufacture a product, takes about 3 to 4 weeks, and the patient can lose their performance status and not be good candidates for therapy. So this is an off-the-shelf. You can treat patients right away, and I think that it will make it more accessible. Maybe we'll get more patients to get this form of therapy as second line, as opposed to more palliative approaches. And we anticipate this to be potentially curative, like other autologous CAR T-cell approaches.